My name is Teresa Jakes, Director of Intensive Care at St George Hospital in Sydney, and my co-coordinator is Janice Gullick, who is the postgrad ICU coordinator for the Sydney University Nursing School. We will be on a research fellow at the Sydney Local Health District. We will be chairing this session. We've decided that we're going to introduce the speakers, they'll speak, and we'll have questions at the end of each speaker. And we've asked them to attest to the fact that they can understand this sign, so we'll be on time. So hopefully we'll get a chance for lots of questions. Please turn your phones down.
Can I just point out, if you're using the conference app, you can go press on the interactive session and you can enter discussion points or questions as you go, and it should come up on the screen.
Right, so it gives me great pleasure to introduce our first speaker, Stephen Honeybul. I've met Stephen on several occasions at meetings around the world. And I always enjoy his speech, so I'm looking forward to today's. He's a neurosurgeon with a special interest in neurovascular surgery and neurotrauma, and he's appointed across Perth at all of the hospitals that I know of, so he's very active. But he also has a great interest in medical ethics and the law. So I'm very much looking forward to him speaking on hypothermia, an extremely controversial topic from a neurosurgeon's point of view. Thank you, Stephen.
Thanks very much. I'll press the start button. 15. Here we go. Right. Hypothermia must be good for you. There's the ICP. Now, we live in the world of evidence-based medicine, which de-emphasises clinical experience and pathophysiological rationale. I disagree with that. I also disagree with the fact that actually the pyramid of evidence has background information and expert opinion as the lowest forms of evidence, and I'll show you for why. Because you've got to understand what you're talking about with hypothermia. There's a neuroexcitatory cascade and there's a Monroe-Kelly doctrine. And what do? We've all been there. I was there last night with a patient like this. What are we going to do? Thiopentone, head up, hyperventilation. Now, how do we navigate this difficult ethical and clinical pathway, looking at the evidence? And I've enlisted two modern-day philosophers to help me. Friedrich Nietzsche, who said there are no facts, only interpretations, and John McEnroe. John McEnroe served at the first round of Wimbledon in 1981, and the ball was called out. What had he seen? Chalk dust. He's an expert. He saw a whiff of chalk, which means what? The ball was in. You've got to know how to analyse evidence. You've got to be an expert, and you see why I feel like this all too frequently when I look at some of the evidence and the way it's presented. So why do we call patients? I'm talking about therapeutic, not as a life-saving, but therapeutic hypothermia. Well, why does your brain go from looking like this, acute injury and death, 6 months afterwards, your brain looks like that? I've got plenty of patients whose brain looks like that on a CT scan. And why is that? Well, when you go through a windscreen at 90 Ks, you get a vast amount of glutamate and other neurotransmitters released into the extracellular space, often cause immediate cell death. But in the minutes and the hours and the days thereafter, this stuff hangs around, and it causes collateral injury, which is why your brain slowly shrinks. I don't care if your liver, spleen, bone, you can regrow those. You lose brain cells, they're gone. And again, billions of dollars have gone into try and somehow interrupt this cascade. Because we talk about raised ICP and treating ICP, but realistically, it's an end organ. By the time the brain's swollen and the ICP is starting to rise, the damage has been done. What we're trying to avoid is this, secondary insults, trying to preserve perfusion. There's no doubt in the lab, huge amounts of neuroprotection can be seen and demonstrated. No doubt whatsoever. It can do all these sorts of things, okay? Reduce the inflammatory response, reduce apoptosis, clearly demonstrated. If you don't do it within 2 hours of the injury, no animal study has shown neuroprotection to be beneficial within 2 hours. I know. Now, the Monroe-Kelly doctrine. We all know about this. Blood and CSF, glial tissue, neuronal tissue, the ICP normally, while you're lying flat, not standing up, is between 10 and 15. As the brain starts to swell, blood and CSF get squeezed out, and you move along the pressure volume curve. ICP starts to rise until you run out of compliance, and that's when you fix pupils and stuff like that. Now, why do we pressure monitor? I often ask this question, I get blank stares. Why do we put a monitor in? 3 Ps. Predictor. Anyone else? Perfusion. Anyone else? P? Pathology. Okay? That's why we stick monitors in. But does absolute control of the ICP change outcome? I mean, you're all sitting there going, of course it does. Come on, honestly. And again, in my 25 years in neurosurgery, for years we've used these therapies. Hyperventilation, barbiturates, hypothermia. Whoops. What's happened there? Oh. Because again, we used to routinely, patients come to the door, we would routinely put them on a ventilator and hyperventilate them for 3 or 4 days. The ICP will come down. What does it do to your blood vessels? Does that. Lowers the ICP by reducing cerebral blood flow. The last thing the injured brain needs is less blood. And again, we used to do regular perfusion studies looking at blood flow, and we'd show scans like that going, that can't be good for you. That can't be good for you. I'm just a neurosurgeon, but I don't think that's good for you. That looks good, doesn't it? It looks good, but that doesn't. And again, if you look at this paper was published in 2010. We're slowly starting to realize that actually, if you hyperventilate someone, that affects the alkalines the CSF for how long? 2 hours. Thereafter, the effect is gone. So we still use hyperventilation if someone fixes a pupil and we go into theatre, but routine hyperventilation, no. Barbiturates. We used to use barbiturates by the bucket load in my old unit. And he does lots of stuff in the lab, no doubt at all, okay? But when you give barbiturates, what happens? The ICP comes down at the end of the needle, doesn't it? Lowers your metabolism, does that to your blood vessels. The last thing the blood vessels, that the injured brain needs is less blood. And you quite rightly turn around and say, well, actually, these studies showed no benefit. Also, all this stuff here, which we know about, cardiac suppression, pneumonia. But we still use barbiturates, because those were done in the days where we used to routinely hyperventilate fluid restriction and give steroids. So actually a modern day use of barbiturates, I think you can argue for. Someone trying to tell me something. But again, we use it in hemodynamically stable patients as a last resort. Okay, so we're seeing these routine therapeutic options being pushed back more and more. Hypothermia, okay. We've already said it does lots of stuff like this. It affects the actual cascade. So it's important to appreciate that. But unless you get your core temperature within 2 hours, any neuroprotection is lost. I'm more than happy to be shown the paper that shows after 2 hours there is neuroprotection. So what does hypothermia do? It does that. That study's in 1954. Plenty of studies showing what it does to cerebral blood flow. It lowers the ICP and a life-saving intervention, but therapeutically, does it make you better? So what's the evidence? What is the evidence for hypothermia as a therapeutic option? Now, there's no doubt studies have been done showing it reduces ICP. There's no doubt it causes significant complications, as we all know. Pediatric study, 2008, was stopped halfway through. Anyone know why? Double the mortality in the hypothermia group. There are problems with that study. I'll come back to that in a second. Again, Clifton study, early, very early, so under 4 hours most of this, was a good study. No benefit. And the most recently published Eurotherm study, 2016. No benefit. Anyone see some chalk dust there? This is on page 58 of the 126-page supplement. This was not mentioned anywhere within the paper. Anybody? Anybody. If you had a drug that you were prescribing that gave a 10% mortality higher than your control, do you reckon you get through FDA with that? Mortality in the hypothermia group, 34.9 as opposed to 26.6. Sobering. So avoid hypothermia, cool to normothermia. And again, Hutchison was a doyen of hypothermia. Safety concerns, we do not recommend further randomized controlled trials. Again, an option for refractory second-tier therapy. I sort of agree with that, but you've got to realize you're buying time based on ischemia. Significant effect except for decreasing the mortality in Asian patients. I said that at our local meeting, and I suddenly realized half my unit is Asian. It's a bad thing to say, but never mind. Now, this is Alpe d'Huez, and we're about to go up to here, the top cable car, and we're going to ski down the tunnel run here, Black Mogul Run. Any comments? No helmets. I put this up 10 years ago and we got nothing at all, but no helmets. It's obvious now, isn't it? Everyone wears a helmet. One of the biggest life-saving things we can do, forget hypothermia, put a helmet on your kid when you ski. Anyway, this is the top of a Black Mogul Run. This really falls off down here. Now, if you're at the top of a Black Mogul Run and you're snow ploughing, you're in for a bad day. And it's rather like some of the hypothermia studies. They've been done in a situation where they were never going to work. It's easy in retrospect, it's easy. But they haven't really been thought through. 2 minutes. I've got 5 on here.
Yeah, we've got questions.
Oh. Okay. Progression from animal studies that's criticized overhurried and overambitious. So what do we do with this patient? I was going to talk 2 minutes about rescue ICP. Rescue ICP, okay, good study. Refractory ICP reduces mortality, less death in the surgical group, less black. Depending on your dichotomy, does it convert death into survival with severe disability? Yes, it does. There's clear evidence. If you change your dichotomy and say that's favourable, which they have done, your results look a little bit better, but not much, okay? So all these therapies that lower the ICP do so, they come at a cost. I'm not saying don't do them, but realise actually it's not making you better. When I rip the top off someone's head, I'm not making them better, I'm stopping them dying. So, in conclusion, evidence that therapeutic hypothermia is not beneficial. Are you serious? More trials? I disagree. Thanks very much.
Thank you, Stephen. And we'll have a few questions from the audience. I've got a handheld mic, which I'm going to have to bring around, so if you could just raise your hand if you wish to ask a question. And to start off, I'd like to ask, we've heard that hyperthermia is bad and hypothermia is bad, but I'd like a definition of normothermia
exactly.
And what are the margins of safety around that we should be aiming for? Because control of normothermia is a challenge in ICU.
Perfectly good question. I think 36 is reasonable. I think a degree above and below that is where you start to run into problems. And again, as you know, a lot of the time with the manipulation of temperature, we forget the effect that has on the drugs you use in intensive care and the potential problems that can occur with that. So I think, 36 is perfectly reasonable.
Any questions from the audience? No hands up?
Jeff. You can shout, Jeff. I can hear you.
Hang on, Jeff. Don't you wear your voice out.
He could have walked towards you.
Do you need oxygen now?
Okay. I wasn't asking you about oxygen and vasospasm.
No, okay. Thanks, Steve. Look, it's really quite controversial, as you know, still the whole issue of hypothermia. That's put to you that perhaps the issue is the nature of the trials that have been done, which have essentially taken all comers with serious head injury, GCS less than 8, as if they are a homogenous group. And first question is, should we be more targeted in terms of the populations that we're doing these sort of trials in? And the second is, do you think there's room for doing a trial of hypothermia as, if you like, a rescue therapy? I suspect that what it'll show is that you get more people who survive, but with poor outcomes.
Yeah.
But I'd be interested in your
That's
thoughts.
what I completely. If you manipulate the ICP, the brain's delicate. It's like all these things. You know, when I'm operating on it and the brain's getting a bit full, we can call the patient, we can give them osmotherapy, and the brain comes down in front of my eyes. But it's not making you better. It's stopping you dying. And all these therapies we've used, manipulating cerebral blood flow, does not make you better. Now, in answer to your first question, absolutely right. What is the one group of patients who have been shown to benefit from hypothermia? Ischemics, the ischemic patients. What is the one group of patients that are excluded from the hypothermia trial? Hypotensive patients, almost universally. And that's the one group of patients who it might actually be beneficial in. Only might be. So you're absolutely right. And again, it's easy in retrospect. I'm not being critical of the trials, I'm just highlighting the problems. It's easy in retrospect to say they were never going to work, because they might have done, and it look a bit stupid. But you're absolutely right, we have to be more targeted, and we have to emphasize the pathophysiology more. We just don't do ahead and just go take all comers and do everyone. We've got to actually work out what we're trying to achieve. Are we trying to achieve neuroprotection or ICP control? And at what level? And I think the whole thing about the ICP numbers and perfusion, we've got to go back to the drawing board. Yeah, the ICP of 20 and above, that's an association based on a trial done in 1991, Mau. It's the idea that we're going to introduce aggressive therapies based on an ICP of 25. I personally, as you know, don't think so. But I mean, is that reasonable? ICP of 25, are you going to be jumping up and down? Or are you going to say just let it ride? Because once you start manipulating the brain, you're not making it better. Yeah.
Just a quick question. How long after a head injury would you let the temperature rise?
Oh, that's a good question. I don't know is a short answer, actually. I don't know. I actually don't know that. I mean, to be honest with you, I haven't thought that one out. I'd put it out to the rest, somebody else cleverer. What about when would we let it come up again? Because rewarming is a big problem. In the trial, in the pediatric trial, they rewarmed at 24 hours, which is reasonable from a neuroprotection point of view, but from an ICP perspective, you rewarm at 24 hours. Well, when does the brain start to swell? We all know that, 24 hours. So that may have explained why the mortality. But I think in general hypothermia, I'm not sure it's a short answer. Good, I mean, that's a perfectly good question.
Thanks, Steve. Sorry, we'll have to hold it there. Thanks very much.
Thank you.
So our next speaker is Oliver Flower. Oliver's an intensivist at the Royal North Shore Hospital in Sydney. He's got subspecialty interests in neurointensive care and spinal medicine, but works in all areas of the ICU. In recent years, Oliver has focused on web-based educational initiatives, co-creating resources such as the Intensive Care Network, Neuro-ICU and ICU podcasts, and contributing to Life in the Fast Lane. Oliver is a convener of the SMAC conference with Roger Harris and Chris Nixon, and previously organised the Bedside Critical Care Conference. He also developed a research and publication portfolio with a neuro focus and was involved with the CICM Fellowship Teaching Program at Royal North Shore. Oliver also loves being a dad, doing martial arts, graphic design, painting and travelling. Thanks, Oliver.
Thank you very much. There we go. So my name's Ollie. I'm from Sydney. I'm an intensivist. And today I'm going to talk to you about real-world continuous EEG monitoring. Now, I recently watched the Netflix series Stranger Things, which you don't have to have seen to appreciate this, but I really enjoyed the fusion of weird science and 80s nostalgia. And it reminded me of the EEG experiments we've been doing at North Shore. So that's hence the theme of this slide deck. So when Hans Berger, back in 1924, invented the first EEG, he would have had absolutely no idea of where EEG monitoring was going. He was regarded as a quack by his peers and largely derided for what he was doing. And he was more interested in investigating the telepathic powers of the mind than looking for epilepsy. But there's no doubt that what he invented completely changed the science of epileptology and neurology and as an outpatient investigation. But continuous EEG, doing full montage for days at a time in intensive care unit, is a completely different proposition. And that's what I want to talk about today, whether this investigation, this monitoring tool, is something we should all be using to help benefit our patients, or whether it's another example of over-monitoring, over-investigating, adding cost without improving patient-centred outcomes. So a few years ago at the Bedside Critical Care Conference, I gave a talk on continuous EEG. I was a young, fresh-faced intensivist, eager to find a new technology that was going to change what we were doing, and I subsequently then embarked on research involving it. And I'd just done a fellowship in Europe, and I was particularly impressed by what the Americans were publishing on at the time, which was really exciting. For example, Liz Gerard and colleagues published this about a 56-year-old man who presented with intracranial hemorrhage, a left-sided ICH. And for the first few days of his admission, he was monitored with CEEG. This is quantitative EEG data, which shows the first 4 hours of his admission to ICU. I'll just explain what the different panels mean. So the top two panels are power spectrograms. So you've got frequency on the x-axis and time on the y, and the different color bands represent power frequencies. So that when you have like the more the red end of the spectrum, that's the slower frequencies that you might see in a seizure, for example. The center panel here is an asymmetry spectrogram, which basically compares left to right. And the bottom two panels are the amplitude integrated EEG, which basically looks at the total neuronal firing power of that side of the brain and integrates it into a single trace. So at point A, you've got the baseline where he came in. And there's a bit of asymmetry there because the bleed was on the left side, and there are more, there's lower power on that side. Then at point B, there's an electrographical seizure, which is pretty obvious. The delta frequencies, there's more power in them, and the amplitude goes up. The asymmetry is very obvious. This was treated with lorazepam and phenytoin, and the seizure stops. Then at point C, there's another brief seizure, followed by at point D, the patient goes into status epilepticus. It's clearly originating out of the left side of the brain. This was non-convulsive status at this point. And at point E, the patient gets propofol, the seizure's terminated, and they had a CT scan which showed an enlarging hematoma. They eventually went to theatre and had that evacuated. So I found this really exciting. This wasn't endless reams of meaningless squiggles. This was interpretable, colourful data that anyone can see when something's happening with. And it was changing management. You were doing investigations. You were giving drugs based on it, and potentially doing surgery. So this was a real game changer in terms of neuromonitoring from my perspective. So who could you potentially use CEG monitoring on? Well, the main utility is looking at unconscious patients with altered mental state who are at risk of non-convulsive seizures. Who is that in realistic terms? Well, the majority of them, at least where I work, are patients with acute brain injury, acute supratentorial brain injuries, and I usually find them in the neurosurgical unit with intracranial hemorrhage, traumatic brain injury, acute subarachnoid hemorrhage. They can be a medical cohort of patients, such as those with encephalitis. The other group is patients who've come in with status epilepticus, and they're not physically fitting anymore, but they're unconscious, and you don't know if they're still having non-convulsive seizures. It's also been used in patients who've got a coma and you don't know the cause, or patients who've had abnormal EEGs and are at risk of going into status, or patients who are paralysed and they could be fitting and you don't know, for example, patients on ECMO or paralysed for therapeutic hypothermia. And the other group, which is the one I've become very interested in, is ones who are at risk of ischemia. So we've known for years that with carotid endarterectomy surgery, there are EEG changes that correlate with the blood flow to the side of the brain, and you get basically more slow wave epileptiform changes as the blood flow drops. And a particular interesting area is patients who've had aneurysmal subarachnoid hemorrhage at risk of developing vasospasm. You can potentially pick up the vasospasm on EEG and do an angiogram and potentially treat it before they get delayed cerebral ischemia. So this is an area of interest. There's some support for this, but this is really something that's being developed at the moment. But where is the evidence for all of this? Now, this is a very important point because there isn't much good evidence in this area. We know that non-convulsive seizures are much more common than we think, and depending on which paper you look at, between 8 and 48% of critically ill patients have a non-convulsive seizure at some point. But we also know that non-convulsive seizures are associated with bad things. So they're associated with surrogate markers of neurological injury, such as ICP elevations, cerebral edema, lactate pyruvate elevation, glutamate, and neuron-specific enolase elevations. So things that we know that are independently associated with bad outcomes. Non-convulsive seizures are also associated with mortality and bad outcomes, bad neurological outcomes. But whether or not this association means there's causation there, or whether or not treating the non-convulsive seizures means you're going to improve outcomes, we don't know really. We know that if you do continuous EEG, it does change treatment, but whether that should be the case or not, I can't answer. And the only data I could find which supports the actual CEG monitoring itself affecting outcomes comes from an observational study done in America. It was large, and it did suggest the mortality benefit from patients who get CEG monitoring, but there are lots of flaws to this study, and there's no prospective RCT showing that just monitoring CEG actually improves outcomes. But we do lots of monitoring which doesn't have proof of outcome benefit. We put in Swan-Ganz catheters, we use PICOs, and even ICP monitoring itself has come under fire for not having much evidence to support its use. And this is non-invasive. You don't need to drill a hole into the brain to stick this monitor in. It's just an EEG on the brain. You just stick a few extra dots on, right? So what could be the problem? Why shouldn't we do it? Now, it's at this point where I feel a bit less like the fresh-faced young guys and more like the jaded, haggard cop, Jim Hopper, after doing this for a couple of years, because the real answer that we don't do it all the time is that it's a massive pain. The logistics of rolling out this service are enormous. Not only do you need to have the equipment, i.e. a continuous EEG machine for every patient you're doing it on. You ideally need a video camera, you need the electrodes, you need the nets to put them on, you need the collodion glue, you need the software to interpret it like that. And it's not quite as simple as whipping one of these nets on. You need to measure it out and make sure the spots are in exactly the right place. And if you reduce the montage, you definitely have a less sensitive tool, so that's not really the solution either. You also need the staff to do it, such as EEG technicians, ICU staff, and ideally neurology staff to help back it all up. And that all costs a lot of money to do that properly, and that is the major barrier. But how do they do it in America? Because I've got a friend, and I know that there are many centres where continuous EEG monitoring is standard of care, and there are even guidelines in America which suggest that a lot of patients that we look after should definitely have CEG monitoring. For example, even public hospitals with low profit margins are rolling this service out where you've got EEG techs on 3 or 4 during the day and 2 on at night, so 24/7 tech cover, putting the dots on, making sure the impedances are down, making sure that everything's working. You've got people monitoring the screens 24/7 and looking for any signs of changes. And you've also got neurology buy-in with a neurologist on call, just looking at CEG all week, not doing anything else, and reporting all the CEGs every day and advising on treatment and management. So how do they do that, and how can that be possible? And the answer also comes back down to cash as well, because in America, the Medicare rebate for doing CEG is about $1,700 per day per patient of 24-hour monitoring. So you can imagine if you put everyone in the unit on CEG monitoring, you're going to generate a lot of money, and it's worth the upfront investment, and you can make the whole system work. That also makes me skeptical of the enthusiasm and some of the research that comes out of the States, because there's obviously a massive financial incentive to make it work when it can do all of this. So overall, I think, to summarise, this is a really tricky question, and there are lots of answers we still don't have at the moment. I think there's a possibility that continuous EEG monitoring can help a large proportion of your patients change management and improve their outcomes, but we can't prove that at the moment. I think the only way in Australia that we can make this work is that we do it. We can't rely on the neurology service, and I think it's very doable for us to learn how to interpret CEG, and for ICU nurses to be able to put on the dots and recognise some EEG patterns as well. But I think this is something hopefully I'll be talking to you about in the future when we have more evidence to support it. Just quickly to finish, I just wanted to mention next week is when the SMAC tickets go on sale. So if anyone can be in Berlin next June, it's going to be a pretty incredible event. So if you can come to June, come to SMAC, Das SMAC in Berlin next year. Thank you.
Okay, we've just got 1 minute for questions.
That was a great talk. Thanks very much.
Thank you.
Can you let us know, because when we're at the bedside in the middle of the night looking at the squiggly lines in the intensive care unit and we're not neuro or electrophysiologists, we don't know what we're looking at. And I don't seem to understand, is there coming in the future the technology to have computer algorithmic interpretations of EEGs that will just spit out what's happening at any one time?
Yes, and it exists at the moment, but there are problems with it. So the quantitative EEG has got seizure detection software on it, and it can process the data in a quite advanced way like that. But the problem is that lots of things cause artifact, and our patients don't just lie there still all the time. They're wriggling around, they pull dots off, they have their teeth brushed, there are other machines in the room that cause artifact, and that's what makes it hard, and that's why you need the video on at the same time. So when you see an event, you correlate it with the video to make sure it's real, because you don't want to change management based on an erroneous result. So at the moment, it's not completely automated, but with that quantitative EEG, it's a lot easier to interpret than it used to be.
Okay, thanks, Ollie. We might move on to the next speaker. It's my pleasure to invite Professor Wes Eli to the stage. He's one of our keynote overseas speakers, and he's passionate about care of the elderly in the intensive care unit. We've already heard some excellent presentations on the importance of diagnosis and treatment of delirium, and in this talk we're going to hear about postoperative cognitive decline, fact or fallacy. Thank you.
Okay, let me figure this out here for a second. Thanks everybody for allowing me to present in this session. I love these topics, and there's a nice thread running through them. My presentation that I've been asked to present on is this issue of postoperative cognitive dysfunction. It was kind of funny that I got asked to present on this, because I don't think that the organizers knew that we had a paper coming out right now on this topic. So I was surprised to get asked to speak on this. So what I'm going to do is I'm going to tell you some of the story behind the term of POCD, why people began to think that anesthesia surgery was creating a problem of postoperative cognitive dysfunction. I'm going to point out a few of the fallacies in the name, and then I'm going to show you a new study that just came out last month in the Annals of Surgery, which, as I said, dovetails very nicely with this topic about POCD, is it fact or fallacy? So I have, in terms of disclosures, I forgot to put my disclosure slide on this. I'm not talking about any medications, nothing related to industry, so I have no relevant disclosures here. I'm funded by the government of the United States, the National Institute of Health, and the VA system. We are going to have VA patients in this study that we published, so I do want to reveal that I have funding from those two federal agencies to do this work. The reason we got interested in it is that people thought that back in the 90s, there was a slew of about 100 papers that came out that said that things like CABG and bypass surgery created a postoperative brain dysfunction, right? You know, the term pump head, for example. And so as we began to try and unravel what in the area of critical illness was leading to this long-term brain dysfunction, surgery became one of the main questions. You know, whether it was general surgery, cardiovascular surgery, don't put neurosurgery in there because it's obviously wholly different. You're dealing with the actual brain itself. But when you're not operating on the brain, is something going on surgically from here down, creating a problem on the back end of it from here up, is the general idea. And this is one of the most famous papers, this Newman study. It was published in the New England Journal of Medicine. This obviously, by looking at the title, was on CABG. It was a very famous investigation that looked at 5-year outcomes after CABG and said, look, Houston, we have a problem. And if you look a little further into some of the other literature, here are 3 bullets for these 3 investigations, which as I said, there are hundreds of these papers, but I just picked 3 of them. So these are 3 studies that support the concept of POCD. But let's look at them a little bit. So the first one, this Moeller study, the duration of anesthesia and repeat operations was associated with POCD at 1 week. So 1,200 people, that's a lot, but 1 week? I mean, that's not that big of a thing. Maybe they get better, for example. Second study cited here, a randomized control of only 47 people, so small. But they did see a problem with general anesthesia associated with worse cognitive function. So you look at the paper and you say, what cognitive function are they measuring? The MMSE, the mini mental state exam. Pretty basic stuff. And how big of a deal was it? So the MMSE went from a 26.5 to a 26? Are you kidding me? I mean, this is not even clinically relevant. You would never even be able to tell that, and the person probably wouldn't know either. So the third one I'm citing here is general anesthesia may increase the risk of POCD. This was a meta-analysis of 21 studies, the average size of which was 100 apiece, and the odds ratio was 1.34, but look at the confidence limits, 0.93 to 1.95. So that's a pretty strong may, or actually I should say, it's a weak use of the word may. I mean, I would just say no association. It's statistically negative. So what about what started to punch a hole in this literature? What started to punch a hole in the literature were studies like this one. This is the very famous octopus study, which was actually a randomized controlled trial that didn't see a difference in cognitive dysfunction once you randomized patients to on pump, off pump. And this is one of the most well-done RCTs that said maybe this is not a real thing. And maybe it's a real thing for the brain, but maybe it's not related to the surgery, is the point. So we're going to keep going. Other things that began to make me doubt the veracity of the causality of the surgery itself versus the anesthesia were things like this. If you look at multiple studies, there just was no dose response seen in these circumstances. For example, in the first sub-bullet there was no, outcomes were similar whether or not it was percutaneous procedures requiring sedation or invasive surgeries requiring general anesthesia. Also, regional neuraxial versus general anesthesia. Depth of anesthesia didn't matter. And duration of surgery, anesthesia, insult did not correlate with outcomes either. So whether or not it was different patient populations or different durations in the OR, different types of anesthesia, we began to see a bunch of things just really punching holes in this story. This is a kind of a neat example as well. This is a very recent study published in the Journal of the American Geriatric Society. And here you've got almost 4,000 people studied in a community cohort. Again, it's self-report, so that's not strong methodologically. However, it's 4,000 people, and they did the best they could with this particular study design. But look what they found on that second and third bullet in the middle. High-risk surgery was not associated with dementia, or AD, and the low-risk surgery actually had a reduced risk. So it went in the opposite direction of what the hypothesis was that was generated there. And this is one of the most interesting studies in preparing for this talk that I was going to deliver to you. I didn't even know about this study, but in 2016, there was a study of twins from Danish, and this is kind of a complicated graph, so let me set it up for you. Go across the x-axis, and you've got, let's see if this works. So you've got 24 years ago, the surgery, out to 24 years ago, and then more recent, up to 2 years ago, 1 year ago, 3 months. So this is more recent surgery. This would be the more definitive version because it's a lot longer ago, perhaps if you wanted to see about truly long-term outcomes. Then the color, the y-axis is the mean difference in the composite cognitive scores. So above 0 is the fact that means that the twin, as compared to the non-exposed twin, did better than the person who got surgery did better than the person who didn't get the surgery. So if surgery was causing a problem, you'd expect all these down here. Okay? But instead, for hip and knee surgery, for example, you see across the board, well, that's not statistically significant, but better for the twin who got the hip or knee surgery, even better. This was, some of these aren't significant. But there's clearly no storyline here that of these two twins, the one of the twins who got surgery did worse than the one who didn't. So again, I'm kind of like, well, not exactly sure about this whole story of POCD. Then, and again, I'm not doubting that these patients have a brain problem long term. What I'm doubting is that it was related to the time they went into the OR. And I'll get back to that when I show you our data. So this is a study that made it in the New England Journal of Medicine, and what happens when you look at this graph, I think, is that your eye goes here, okay? But really, what really should happen is your eye should go here, because out here at 1 year, everybody's back to normal. There's not an issue, and who cares really? I mean, I guess it would be a bummer when you do have a cognitive dysfunction at age 2 or 5. I mean, for at 2 or 5 days, but as long as you could reassure somebody that, give me some time, you're going to come all the way back to your age-predicted norm, then I think that's a good message. So I even emailed the authors in preparation for this talk to say, is this real? Because I actually think that I missed this when I saw this paper come out. My brain was all like, wow, if you had 3 days or more of delirium, you had a big deficit here. But now that I'm preparing for this talk that I'm going to give in Perth, my brain is all over here that they're normal, and they wrote back, yeah, that's actually, we didn't emphasize that, but if they had emphasized it, it would have gotten in the New England Journal, perhaps. So, okay, so here are the data that we just published. These are data from, I presented earlier about our brain ICU study. It was an NIH-sponsored cohort study. We had 800 people in it. Well, what we didn't have at the time that we published our original New England Journal paper, we didn't have the other cohort. So at the time that we put these grants in, we put one in at the NIH and one in at the VA. And so we actually had 2 concurrent cohorts building during this time. We called the whole thing the Brain ICU Project. And the idea was that we would get civilians and soldiers and study across the spectrum of these different types of patients to really bolster the robust nature of this analysis. Okay, so this is the first time I've ever presented data that actually included the whole 1,050 patients. I've never presented this paper before. So what we decided to do was to look at this multi-center prospective cohort across the community and the VA. We had 1,040 people in it. We looked at demographics and hospital course data for 30 days, and then I thought I had 30 minutes.
Oh, you do?
Okay.
Carry on.
Otherwise, I'll never be able to finish. Okay.
Just testing. Okay,
you're very good. So otherwise, I'll just have to give you the punchline. So then we looked at 3 months and at 12 months. And so about 500 people at 3 months and 400 people at 12 months. Now that's about 80+% of the survivors. Remember, these people die a lot. So we lost about half of them to death. Of the people who lived, we got 80% of them back for these follow-up visits, which is not bad. I wish it was 100, but 80 was hard to do. So anyway, then I want to explain to you the 2 analyses that I'm going to show you. 2 different linear regression analyses. One linear regression, which was surgery plus baseline covariates, and the other one, which was surgery plus baseline, and nobody's done this before, hospital covariates. So people didn't have these hospital covariates that we analyzed. They had severity of illness, but nobody had delirium, drug exposure, things other than the OR, which could have contributed to the long-term problem. Okay? And I think this happens in neurosurgical and trauma patients too, by the way. In other words, whether you go to a cardiovascular unit, a trauma, a burn, a medical, a surgical, what we're learning here, that the end of the story is that these ICUs are more in common than they are disparate because of what happens in the unit. So it doesn't matter as much what happened in the OR as much as that everybody's on mechanical ventilation, a lot of sedation, a lot of delirium, and so on and so forth. And that's what we were trying to study here. So the novelty here is that we had surgical and medical patients. Most of the people looking at POCD didn't have a so-called medical control group. There was major non-cardiac surgery, very high severity of illness, Apache scores in the 25 to 27 range. That's very sick. We had detailed hospital course data, and we had high follow-up rates with in-person evaluations. So these were hour-and-a-half long in-person cognitive evaluations, not an MMSE, not over the phone. You couldn't get more laborious to do this. In fact, if they didn't come to us, we get in our car and drive to them. We had gas money, everything to do this. So I don't ever want to do this study again. It was miserable. And what we found was that there was not a shred of difference between the surgical and the non-surgical patients. I'll set this up for you. So this is the median value here in dark. This is the 25th and 75th percentiles. This green line is the normal for the R bands, which is this comprehensive neuropsychological evaluation, and the green band is the standard deviation of error around normal. So what you see here at 12 months, this is 3 months and 12 months, we'll just look at a year, is that the global cognitive function was the same whether it was surgical or non-surgical, and all of them were well below the normal. Well, no, not all the patients, but both groups, the median was well below normal, and in fact, the lower quartiles were hovering around what would be consistent clinically with traumatic brain injury or Alzheimer's disease. Right, that's true for global, and it's also true for executive function. So this is, can you do your computer? Can you go to the store and get all the things you're supposed to get? Can you remember people's names, et cetera? Things that really bother people when they get out of critical care if they can't do it, and make them lose their job, by the way. And here are the two analyses. A lot of numbers. I'm just showing you 2 points on each of these next 2 slides, this one and the next one. So the top is the first model, which was surgery plus baseline covariates. And then this bottom set of data are surgery plus baseline plus the hospital covariates. The methodology, the journal really liked that we had both of these models. And there's 2 take-home points on this graph. The first one is that surgery was not predictive, okay, at either global R bands or executive function, p-values of 0.2 and 0.9. In the simple model, surgery was also not predictive in the more comprehensive model here. So surgery did not predict univariately or multivariately. And the second thing is that delirium was the most consistent predictor of the long-term problem. Delirium duration. Very significant predictor of a worse cognitive function according to the duration of delirium. And that was 3 months, and the 12-month data were totally consistent with that. Surgery, nada. Delirium, yes, sir. So those were my 2 take-home points. And then I wanted to close by presenting to you if the delirium is a problem, and if delirium is what happens in the unit, out in the world where you're caring for them, then what do you do about that? And just a very brief commentary about what we're trying to do about that. So what we're doing is we're taking hospitals all over the United States in this ICU Liberation Collaborative, and we are implementing this bundle of care, which is called the ABCDEFs, and these are evidence-based upon about 200 to 250 peer-reviewed manuscripts and about 35 manuscripts that came from the New England Journal, Lancet, or JAMA. In the last talk, I showed the references for the New England Journal, Lancet, and JAMA. The main point is that this is not just cute. Okay, it sounds cute because it's alphabet, so alphabet cute. The point of it being the alphabet is that you can remember this. To tip something, you should have it be a sticky message, something you can remember and use in the ICU. And what we do is we take this bundle, and at the bedside of medical and surgical patients, we implement this bundle like we did in this 6,000 patient cohort study. And at the bedside, we then, on rounds, at every bedside, we talk about the A to F bundle for that patient. How did we do it for Betty Smith? Then how did we do it for John Thompson? And then every day, we try and stay compliant with the different individual elements of this bundle. And these data from this 6,000 patient cohort study, which will come out in Critical Care Medicine in February, so in a couple of months, these data are what we found in this particular study. As you go across the x-axis with increasing degrees of compliance with the bundle, so we actually, for the first time ever, looked at, was there a dose response of compliance with the bundle and the clinical outcome? There's another 10 studies prior to this one that looked at the bundle improving outcomes. And I'm not going to show you them because we don't have time. But there's plenty, there's 3 tiers of data that I want you to be aware exist on this. The first tier of data are individual studies at the level of stopping sedation or paying attention to the choice of drugs or monitoring delirium or early mobility, family involvement. And those individual things were published in the New England Journal, JAMA, and Lancet. Then the second tier of data is when you put them together as a bundle, does it work? Because individually it might work, but you got to test it as a bundle. And then the third tier of data is this study where you look at the dose response of the bundle, because that's where it can get convincing. And in this one, as you went up every 10% in compliance, you see that we had, by multivariate analysis, after adjusting for severity of illness, age, and on or off vent, you see that every increase in 10% gave us a 15% odds ratio, 1.15, statistically significant odds ratio, 15% increased likelihood of survival just by following this bundle. Okay? And on the right graph, you see freedom from delirium and coma. My hand is a brain totem pole. Here is coma. Here's not neurocoma, not macro trauma, micro injury. Okay, so these people don't have ICHs, subarachnoids, etc. They've got delirium in the ICU in the absence of macro injury. Coma, delirium, normal. Freedom from these two. Freedom from coma and delirium means you're up here. This is what we saw. Every 10% increase in compliance, a 15% increase in likelihood of being free of delirium and coma. So you could consider, in your unit, adopting a program at the bedside for clinical management. What this graph shows you is that you're monitoring for these symptoms, pain, agitation, and delirium. You're using these tools, these evidence-based tools, to do that, and the steps of the implementation are shown here. So you check, did you do A, did you do B, did C, D, E, F. And then I'll just close with, what do you do with the information if they're delirious? For example, the last talk, we had a wonderful woman tell us that, look, I've been doing this for a while, but my nurses want to know, what am I going to do with the information? And some people think if you're delirious, you automatically knee-jerk and start like an antipsychotic or something. No. Instead, you do the other things that are not starting a medicine. For example, you pay attention to the Dr. Dre. You do disease remediation, like, is this person newly septic? Is their CHF getting out of control? What's going on medically with their illnesses? Then drugs, which drugs should be removed? Okay, is this person delirious because I have them on sedatives that are deliriogenic that really they don't need? Let's get rid of these drugs. Let them wake up. Let the brain clear this stuff. Okay, what about the environment? Are they blind? Do they have hearing aid needs? Do you have them restrained, immobilized, and tied down? Because if you put me in a bed, tie me down, put a tube down my mouth, I can't talk or communicate, and I have visual or hearing problems, I'm going out. My brain's going to whack out on me. So undo all of that. After you've done the Dr. Dre, you will find, I'll tell you this, in the ongoing RCT we have right now, we've enrolled 1,200 patients in an RCT, NIH-sponsored RCT of antipsychotics versus placebo. The background therapy of the entire thing is the ABCDEF bundle. At the beginning of it, we powered it on 75% delirium rates. Just with the ABCDEs, we're down to 45% delirium. So you can dramatically reduce the prevalence of delirium just by doing something like this Dr. Dre. And that's it. I hope that was helpful to you and interesting. I'd love to see if you have any questions or thoughts, but I appreciate the chance to present to you. Thank you.
So we've actually got a few minutes for questions from the audience, and we've got some. There's George. Can I just ask you,
please?
We know certain comorbidities, pre-existing comorbidities, patients do worse after a critical illness. Metastatic cancer is one of them, but one of them is dementia, the presence of dementia. In your study, do you have any subgroup analyses, and is there any impact on surgery and anaesthesia on those patients with dementia, or is it different to that?
Right, it's a great question. So a priori, we wanted to evaluate if there was a pre-existing cognitive impairment. So back to the brain totem pole. Is somebody coming in up here at the top of their brain totem pole, or are they already knocked down a little bit? Because we know that delirium on dementia is a thing. As my daughters would say, Dad, that's a thing, that's not a thing. If they come in down here, then they have less neuroplasticity, less likely to be able to bounce back, per se, et cetera. In this cohort, we screened out any moderate and severe delirium. We didn't want it because...
Dementia, delirium.
I meant dementia. Screened out any moderate and severe dementia, and to realize that they might have some dementia, but it not be characterized in their chart or pre-diagnosed, we did an IQ code and a CDR, which is a clinical dementia rating scale, via their surrogates. Remember, these people were emergently ill. All of this 1,040 patients were on a blower or in shock. So all of these 1,000 patients were severely ill enough to be in respiratory failure or in shock. So we couldn't ask them. So we asked their qualified surrogate, meaning 5 years or more of surrogacy, and only 6% had any dementia in this study. So largely it was a non-demented cohort. Yeah. Next question.
The reason we've been working together too long, I was going to ask exactly that question.
Yes, yes. I can't tell you about the role of surgery on top of dementia because this cohort didn't really have a demented group in it. But don't be bashful. What other questions do you have? Anything at all?
We've got a little bit more time if there's...
In the Danish study where they were looking at hips and knees, did they exclude spinal anaesthesia?
I can't tell you the answer to that. I'd have to look it up. I'd like to know. That's a good question, and I don't have it in my RAM. I'm sorry. Are you talking about the twin study? Yeah. No, I'll have to go back and look at that. And if you give me your email address, if you can write it down for me, I will email you back after I go read it. Okay, thank you.
You described your data looking at the dose response to the A to F bundle. Was that looking at the efficacy of the entire bundle? Like, was it a binary complete compliance? Or
Yeah, we looked two ways. That's a very good question. We looked both ways. We looked at it as an all or none, which I think is a weaker way to do it, but we did that. And there was a significant relationship between the all or none. But the thing that the reason I didn't show you the all or none is it is positive, and that will be shown in the paper, okay? But the reason I didn't show you that is that I think a lot of people would get discouraged if that was the only analysis because we know in real life that it doesn't work like that. We don't have an all or none. So I thought that the more clinically relevant evaluation of this was across the spectrum of compliance. So that's why I think that's more clinically relevant. But all or none or by 10% increments of compliance, both ways, there was significant increase in survival and significant increase in freedom of delirium and coma according to the bundle use. Excellent question.
We've got time for one more quick question, if anyone's got one.
I will add something as we're thinking, since we have trauma and neurosurgery in the room. This, I think, applies to people with head injury. I told you that we excluded the people with head injury, but we have a paper right now under review at Intensive Care Medicine looking at delirium in people with a macro brain injury. And there is a good body of literature growing in the area of neurosurgical patients with strokes, ICHs, subarachnoids, et cetera, where delirium is predictive in those patients. Using, for example, a tool like the CAM ICU is predictive of a worse neuroquality of life afterwards. So I think you could think of it like this. If you had a cohort of ICU patients who did have a stroke, an ICH or something, they would obviously be down on their brain totem pole. They have a macro injury. They're even more at risk for a problem of delirium contributing to a problem. Think about the delirium on dementia or delirium on neurosurgery. So I don't think that we should think that just because somebody has a stroke or some macro abnormality on their CT scan or MRI, that all of a sudden we can't worry about delirium because it's more difficult to diagnose. I think it's even more important that we pay attention to those patients if they develop delirium on top of their injury. And the way that we do it is we take their post-neuro insult neuro exam. So once the dust settles after their stroke, we analyze that for changing over time moving forward. And I could get into that more later, but just don't disregard the neuro ICU on this topic. Thank you so much.
We actually have another question, but just on that point, in my just day-to-day practice, I'm always reminded of the elderly patient with dementia, and you add in a urinary tract infection.
Boom, and they're out.
And you treat it, and they go back to whatever their baseline dementia function is very readily.
Right.
Now we have a question from Ollie for you.
Okay, Ollie, please.
Yeah, did you factor in the use of dexmedetomidine into the studies that you've been doing, and has that changed?
Yeah, no, I didn't, because we didn't have a lot of dexmedetomidine in this study. We had maybe 5%-ish, so there wasn't enough power there to analyze it by dex versus propofol, et cetera. However, we do have an ongoing randomized trial of dex versus propofol that we've enrolled about 300 people into, all of whom are septic. It's called MENS-2. Our first study was in JAMA years ago, which was dex versus benzos, which obviously showed a superiority to avoiding the benzos, and now we wanted to do it up against propofol.
Okay, thank you very much. Would you thank our speaker, please?
Thanks. I'd like to welcome our next speaker, Associate Professor Tom Buckley, a colleague of mine at the Sydney Nursing School. And Tom's a registered nurse and academic and currently fulfills the role of postgraduate coordinator for research. Tom has a strong research interest on the impact of critical illness and hospitalisation on patients and their families. He's very well known in the field of research into heart rate variability and its impact on patient outcomes, and has some highly influential work that he's recently published on the influence of extreme emotions on the onset of a myocardial infarction. Tom is currently conducting studies investigating strategies to reduce the impact of bereavement on spouses and parents of people who've died, as well as evaluating the impact of hospitalisation, including admission to ICU, on relatives' own health risk. Tom's a current editor with the Australian Critical Care Journal and chair of the Australian Nursing and Midwifery Council for Nurse Practitioner Accreditation Committee. Welcome, Tom.
Thanks, Janice. And just for the record, I didn't write all of that bio. Janice knew me too well. Okay, palliative care in ICU. We could look at this from many different perspectives. And we look at it from the patient perspective. I want to look at it a little bit from the survival family member perspective. But of course, we probably expect me to talk about it from the perspective of healthcare providers, from nurses, physicians. But I'm not really. I'm going to talk about it from a researcher's experience and also from what I learned, because my almost 15 years working in ICU did not prepare me for what I experienced in this study. And just like the previous speaker said, he never wanted to do that study again, I never want to do this study again I'm going to talk about, because of the impact it actually had on both I, my family, and the other members of the team, although we do continue to work in bereavement. And the reason for that is that, you know, we all accept that death is universal and inevitable. But there's a big difference when you're a clinician at the bedside in managing the care, either withdrawal of care or end-of-life care for a person and their family. And while at heart we would all be thinking about the patient, we're probably thinking more about the family in that latter stage, particularly if the patient's unconscious. It's very different when you see that person and the family in the ICU. And then, as on many occasions you saw the removal of the deceased person, which, you know, it's never a pretty box, is it? The way it's draped, it's pretty obvious what's been transported out of the ICU. And then when you see the family in their home, and I can give you examples of where I was taking blood or putting on heart monitors, Holter monitors, doing physiological monitoring, psychological monitoring in husbands, wives, or parents of deceased individuals a couple of days after they died. And their children would be pulling out of you. I remember one occasion, one of the kids, 3-year-old, giving me a hot cross bun. And he was more concerned with me having the hot cross bun as I was getting the blood out of his dad's arm, making sure I didn't have the tourniquet too tight and destroy the platelets. And I remember just sitting there and going, this is something very different here. Why would I wake up in the middle of the night thinking about those scenarios after 15 years working in ICU? I probably never thought about that scenario. And so these type of studies are very hard. The other thing about this type of study is, after I first presented some of the data I'll present here at American Heart, I got a phone call from a probably the world's top psychology bereavement expert, and she said, Tom, and I won't mention her name. I do now collaborate with her, so maybe she wouldn't mind me mentioning her name. And she said, I tried to do this and failed for my whole career. How did you manage to do it? And I think the reason we managed to do it was we did it in a centre of excellence. We did it at Royal North Shore Hospital and a couple of the surrounding hospitals where Ollie's now working. We did it in an environment where we had a multidisciplinary team of social workers, pastoral care workers, nurses, doctors, scientists, who truly, truly wanted to do this. And the insights it gave are insights you don't get necessarily in the literature. But we weren't there studying palliative care. We were actually there studying the effects of bereavement on cardiovascular health. But what I want to present today is some of the stuff that I've published recently related to those unmeasured learnings and some of the things that we looked at as predictors for the relatives. Because I did a session earlier and got challenged on, the macro evidence related to something. But I think the problem with systematic reviews and even meta-analysis is they don't always highlight the individual, and they very rarely highlight the individual's experience. And so some of the data I want to present here is related to their experience. So where do people prefer to die? Well, there's a general acceptance that people prefer to die at home. And in the public surveys, about 2/3 of people prefer to die at home. But it is considerably variable among studies. So when we say most people want to die at home, some of the studies showed only about 25% of those samples want to die at home. So there's often a very big difference between what actually dying at home entails. And when the reality comes as to what actually occurs when somebody is dying, you actually find that a significant proportion of people, when it comes to it, don't actually want to die at home at all, because it doesn't necessarily mean it's a comfortable death, even if the environment is correct. When you look at patients with chronic disease, about 80% of them prefer to avoid hospitalization and particularly avoid ICU. And that makes sense because who does want to visit hospital to start with, let alone ICU? But actually, what they really want when you come down to it is most people, this is now general population surveys, most people want a quick, unexpected and pain-free death. Who here doesn't want that? Yeah? But there are advantages, as I learned in my research, there are big advantages to actually knowing you're about to die. And so while the surveys say that of people in the idealistic world out there having a beer and a coffee around a dinner table filling in a survey, in the reality when it comes to it, a lot of people who have been given a diagnosis of impending death sometimes actually value that period and preparation more than the individuals out at the dinner table. And so I think we have to look at surveys and look at the context, and we all know context is important to everything. About 80% of people die in institutions. In Australia, 51% of people who've died in Australia die in a hospital setting. In the UK, it's 63%. I'm not quite sure why it's different. But when you add in other institutions, about 80%. So really only 20% of people are actually dying in home, despite the fact that in the general surveys, most want to die at home. I probably don't need to tell an audience like this around the mortality rates related to patients in ICUs, and it does vary depending on the type of ICU, what the mortality ranges are. But there's somewhere between 10 and 30% in the adult ones, and there's somewhere between 2 and 6% in the pediatric ICUs. Why would we not want to die in hospital? Well, the first thing, hospitals are terrible, horrible places, aren't they? I mean, who likes to be in hospital? I always loved working in them, but I hated when I was a patient. And so there is some evidence, emerging evidence, that hospitalization itself actually increases the cardiovascular risk of the person, the immediate carer, the relative, husband, wife, or parent of the hospitalized person. And as a matter of fact, at 30 days, hospitalization alone confers as much risk to the person, the carer, or the close carer. I'll call her carer, but I'm really talking about spouses, parents, or spouses, parents, or partners of the hospitalized. Whether or not they died or not, the hospitalization confers as much risk. In other words, the same number of people at 30 days will have mortality risk whether or not the relative died or not. And as a matter of fact, in the ICU setting, the same number of people will have PTSD, the relatives will have close family members, those carers, will have the same number will have PTSD, whether the person died or not at 6 months. So think about it. Whether you would think whether the person surviving ICU is going to be hunky-dory for the spouses, but actually the same number have PTSD as whether or not they died as they do complicated grief. So hospitalizations itself, and I'm sorry these slides might not be very clear. I just noticed when I uploaded a few minutes ago, it didn't come out very clear. But hospitalization itself confers for a man after hospitalization of his wife, the 30-day hazard mortality risk is 1.35. Now you might jump up and down and say it's not very high, but it's significantly there and is consistent with tight confidence intervals. And likewise for a woman it's 1.44. So something goes on, and that's controlling for everything. That's the hospitalization bit. Okay. Now, intensive care families, when you look at what they actually do, just give me good timing. Yep. Yep. The families themselves will give priority to the ill relative. And I think actually we probably do that as clinicians too. You know, the major focus is on the individual, and particularly if they're dying, you know, the focus is on the individual. But for the family themselves, as they're going through an emotional heightened state, they have a high fear of death for the relative. These are things we know. These are things we know as clinicians. But they've been borne out in the studies. About 40% have perceived conflicts during end-of-life discussions. And trust me, they matter. When I was studying people in their home 1-2 days after the death, these are the things I was listening to. These were the things I was filtering through. And the conflicts are nearly always related to communication and the behavior of staff. and I could tell stories that I'm not allowed to publish because they weren't in my ethics, but if I could tell stories about what people say and do in front of relatives that have major impact on the perception the relatives have of the care delivered, I would shock you. But you can't publish that data, and that's what I call about unmeasured learning. But I'll go through some of it. If you look at the relatives for post-intensive care, whether they survived or not, there's always concerns about financial conditions. There's always experience of role changes. And so the person who might be the primary provider is suddenly now the primary receiver of care in a family. Disruption to family bonds. And when you look at that, I've already mentioned depression or PTSD, prevalence is very high, and this is for the family members. Depression and anxiety is likewise quite significantly higher, and higher than population norms. So these symptoms, when you look at the literature, they're very dependent upon the relatives getting honest, accurate information. This is what the studies bear out. This is what I experience. This is what they continuously tell me, my current studies. They want honest, accurate information, irrespective of whether it's what you think they want to hear. They want honest and accurate information. I always talk about the honest lie. When I first started working in coronary care, and the patient, who looked like, he was about to have a second heart attack in front of you. Nurse, how am I looking? The classic example is, oh, you look fine. When the reality is they don't look fine, and they've probably got impending feelings of doom. The reality is we should ask them, why are you asking me, rather than tell them what you think they want to hear. What we do know from the literature is that families want conference rooms and they want late and flexible visitation rights. But we know we've got very good at that. But this cluster of symptoms is called post-intensive care syndrome family, because we want to designate it's the family, because we are all usually focused on the patient. Now, when we look at bereavement itself, what we see from another angle is that there is an excess. So if my wife dies, then I am about 16-fold more likely to die myself in the next 2 days. And that continues out to 6 weeks. And at 6 months, I'm still 40% more likely to die. And there's been and what do people die for? What is the excess mortality and bereavement from? And about 50% of it is from cardiovascular disease. But neoplasms and infection do make up a significant proportion, and also accidents and suicides. And I do wonder a lot about how many of the excess accidents are actually suicides. There's lots of suggested hypotheses around this shared pathogenic environment, the fit marry the unfit, etc. But even when you control for all of that, there's still a significant excess mortality in the survivor. So we did a study based at our Royal North Shore Hospital where we thought, let's see if we can unpack what's going on physiologically that would explain this heightened vulnerability to mortality and cardiovascular disease following the death of a spouse or a child. And so we did a two-group prospective study of 80 spouses compared to 80 spouses and parents compared to matched controls of survivors, and the survivors were from orthopedic areas, trying to control for hospitalization, not the critical illness. And we followed up at 3 and 6 months. And we published the findings, and just to give it the short version, we expected significant psychological response, and we knew there were modifiers in there. The social support that people wanted is not the social support you give them, it's the social support they want, and that's a very important thing. When you enforce psychotherapy, when you enforce social support on people in bereavement, you do harm. The studies show consistently cognitive behavior therapy that's enforced does more harm than good. It has to come from the relatives. You can offer services, but the relatives have to need to want them to see good, favorable outcomes. We saw behavior change, sleep, alcohol, things that we would expect. Some were anticipatory grief responses that carried through, and some were actually responses that carried following the death. And then we saw what I call the perfect cocktail or perfect storm of physiological changes, heart rate variability, heart rate, blood pressure, prothrombotic, inflammatory, immune changes that actually help to explain why we are so prone to cardiovascular acute events during this heightened emotional state. One of the things I wanted to draw attention to was the psychological response, and it's no surprise to see that depressions would be up and come down to almost cut-off levels at 3 months. It's no surprise that anxiety would be elevated but wasn't resolved at 3 or 6 months. anger wasn't high, but when anger was high, it is toxic. And we know from other work that I do with another group that, for 2 hours after having an acute episode of anger, and I mean acute episode of anger, we are 8 times more likely to have an acute cardiovascular event or a coronary occlusion. So anger itself does predispose us to many of those cocktail of changes that we see in bereavement. The patients who did express anger were patients who were angry. There was 3 groups I particularly remember. There were relatives who were angry with the patients for dying. Right? Usually because the patients hadn't self-cared for themselves despite being nagged to self-care. Sound familiar? Yeah. There were relatives who were angry with the patient because of what they found out when they died. For instance, the lady who I later visited at midnight one night because I was her last call before she went to hang herself. Her anger was actually related. Interesting that she contacted me as the researcher and not anybody else. So, we were pleased that we were there, but we weren't there for that role. But this is the unmeasured learning that we had. Her anger was with the husband because she found he had an illegitimate child and he had willed the estate to the child. So the point being is you don't know what you're dealing with. One of my big dilemmas in this study was frequently I didn't know who to approach, the spouse or the partner. And sometimes both were present. And so we'd offer both, but only ever one would come in the study. So it's complex scenarios. And then the other source of anger was anger at people like Ollie who have to make hard decisions. Yeah, hard decisions that they cannot accept, end-of-life withdrawal care decisions. The most angry individual in this study was the youngest, and the youngest individual was only married 6 months, and her anger was totally directed towards the intensivist who had to facilitate the withdrawal of treatment. What are some of the predictors then? Well, how prepared you are for the death seems to be a consistent predictor that we see across psychological readjustment. We did a follow-up. We looked at what are some of the predictors in relation to the death. And you would expect most of these variables, how drawn out the death was, the dying process, how violent the death was, how much prepared they were for the death, and the opportunity to say goodbye. And yes, there were significant relationships with how the death occurred and the resolution of bereavement, particularly at 6 months. But the one that when you controlled for all of these particular factors, the one that propped out independent consistently, both at 2 weeks, 3 months, 6 months, whole way through, is how prepared they were, not necessarily the nature of the death. When we looked at coping responses, we found that coping responses were quite static. In other words, how people cope initially is how they tend to continue coping. And that brings up the question, is coping a state or is coping a trait? And should we work with how people are coping or should we try and teach them how to cope? I would say the former was my experience here. When you look at the relationship between coping and bereavement response, the two that jump out that you would expect is venting feelings. Use of it, people who seek emotional support are clearly the people who are still unresolved at the 6 months. Self-blame and denial were the two. And so my last couple of slides, I just wanted to highlight them, that really forewarning or being prepared is the elephant in the room here. This is our opportunity, is to make sure we give as much opportunity to be prepared. But we need to remember that what we're preparing people for is permanent separation. And I think sometimes we forget that. And many of the relatives said to me was they knew they were being prepared for the death, but they didn't realize they were being prepared for permanent separation. And so it's perhaps the type of words we may need to use. Denial is a very, very poor predictor of psychological adjustment. And my wife says to me, denial is my best self-mechanism, and so it is, but it doesn't mean that it's not going to come out later. So if you want to pretend the washing's done, well, it's going to stink eventually, And in relation to bereavement, people will put up denial and people will look but actually repression of emotions has been shown in bereavement to not be healthy. Finally, self-blame. we should expect self-blame in our relatives, our spouses, our parents, particularly our parents. We should expect self-blame, but we don't necessarily ask the relatives, you know, are you blaming yourself for this? Because if you did, what you'd find is about a third of the time they are. And there's two types of self-blame here. There's one, the behavioral guilt for actions they could have changed that contributed, but there's another type of categorical blame where they actually blame themselves for the death. And interestingly, in a small pilot study where the relatives were encouraged and facilitated to apologize, and it didn't seem to matter whether they apologized to the person before they died or after, they actually had better resolution of symptoms. So once again, teasing out that third who actually have self-blame. So in conclusion, 50% deaths occur in hospital. I think, you know, might be higher in some scenarios, and it's probably not going to change in our current healthcare environment. People prefer to die at home, but they don't. Bereavement is a heightened period of health risk for the surviving family. Being prepared is the most important factor above all nature of the death, whether it's violent, pretty, ugly, it doesn't matter. Being prepared appears to be the most important thing. Look out for self-blame. When relatives self-blame, they have very poor resolution, they have very high levels of complicated grief at 6 months and PTSD, and they are also the individuals that are prone to self-harm later. Relationships are complex, and so is end of life. And I think this individual, the whole problem with bereavement research is that often the individual gets lost. Thank you.
Thanks, Tom. I'd like to start with a question, and I'm interested in how much this preparation for death, the need for preparation for death, is culturally mediated, because we very commonly see cultures that want to protect people from poor information about a poor prognosis, and whether, you know, what you feel about how far we can extrapolate your findings within our own culture.
I think when you do, you know, if I try and stick to the research, because one of the problems with bereavement research is everybody has had experience, and usually our own personal experiences tend to override what the evidence says. What we do know is that there are many influences on people's trajectory in bereavement, spirituality, religiosity, and they are different when you look at it in the literature, and they're very different in my data too. Our cultural expectations are probably the thing that we need to be most aware of. We tend to make judgments on people by their culture, and their culture often being their skin color. But the reality is that it's actually their culture as their behavioral norms, as the society they live in is probably the more important thing. I saw a lot of variation in how people adapt in bereavement among different cultures, but I saw a lot of variation within cultures too. So I wasn't able to come with any predictive model for particular cultures, particularly because I struggled with how to define a culture. But certainly, you know, there are some trends there with religiosity and spirituality, and we don't have time to go into it now, but the trends are not necessarily what you expect them to be. And so we tend to think that the more religious person will have a better bereavement experience. Not necessarily true. Sometimes spirituality tends to be more predictive of better resolution than religiosity. So I think it depends how we define culture, and I struggle with that. And, you know, a white Irish guy who's lived in England, America, Australia, I can't understand Australian culture. I'm still struggling 16, 18 years later. That's probably why I haven't become a citizen yet.
Yeah, we will have to move on. Thanks so much, Tom.
I'd like to invite Deborah Tierney to the stage. Deborah?
Yeah, I'm here. I've got to get through.
Now, Deborah is a social worker, and she's currently the senior acting social worker at Rockingham General Hospital in the ICU, the emergency department, and the medical assessment unit. She has worked in the prison system, the yachts, women's refugees, and child protection. And she's passionate about the multidisciplinary team that's so vital to our ICUs. So I'd like to invite Deborah to present the social work perspective. Thank you.
Thank you. Good afternoon, everyone. Friday afternoon, so we're all falling asleep, I take it. So how about we just get this party started, hey? Now, Am I going to go through?
No, sorry, just scroll back.
Back?
Scroll back and click on your name.
Have I got to put an arrow on my name or click now?
No, just click, put that arrow on your name.
Where is it? Ah!
Click.
I love that song. I think Circle of Life really is how we should describe life. However, I am aware this is a medical conference, so I thought I'd better change that and make it Cycle of Life. I'm going to do a role play for you because I want you to physically think about what is a realistic expectation of what your cycle of life should look like. All right? So bear with me. So we start off with water. A little baby. We can't control our bladder or our bowels. We spit the dummy. No, never as a baby, only when we get older. We learn to walk. So like this, confident and up. Belly sticking out, and spend the rest of our lives trying to get rid of this belly. Okay, if we're lucky, if we're really lucky, we actually get to go to school and we get educated. So, off we go. Education, primary school, high school. We get to high school, we start to develop relationships. And what do we find? We notice the boys and the girls. So, here we go. We go, boys, boys, boys. Beautiful. So off we go. Once we've been educated, we usually go to work. Okay, now, got to do this up. Now, what sort of job are we going to choose? Some of us might become doctors or nurses. With this, we go, no, Mr. Smith, I'll tell you what's wrong with you. I'm the doctor. So, tongue-in-cheek doctors, all right? We might then grow up, meet a partner, and we might decide to get married. We go, I do. We also might be decided to have a baby. So off we go. Oh, never going through that again. Far too painful. Then we become part of the grey nomads. How good is that? I'm really hoping to reach this stage soon. And off we go with our Winnebago around the country. Oh, look, beautiful, beautiful. Right, good. Hopefully we'll get there. Then, our bodies. We start getting really, really tired and deteriorating. So instead of being proud and standing like this, we get nervous and we walk closer to the ground. We also sometimes lose control of our bowels and bladder. So we're going through the full circle. Okay, with that, what happens then? Often, our people end up in hospital, all right? Depending on your life experience, your personality, how you die is quite different. You got grumpy old Mr. Smith in bed 10, pressing the buzzer. Nurse, I need a bedpan, nurse. Nurse's station with respect. Oh, bed 10 again. You want to go? Nah, I'll go. All right, off we go. Beautiful Mrs. Jones, no bother to anyone in bed 8. Never presses the buzzer. Nurse's station. I'll just go and check on that lovely Mrs. Jones. How you going, Mrs. Jones? All right? Don't you worry about me, love. I'm okay. I know you're busy. Beautiful. Either way, end of life. That's it. So what happens then? We get this lot out. Where do we actually end up? Cardboard box. End of life, people. Thank you very much. That was your life mate. Okay, so that's hopefully woke you all up. So now then, I can't completely embarrass social work, so I'm going to have to actually try and be, excuse me, while I just slip into something a little bit more comfortable. Or shall I say a bit more appropriate. So think about that now for me, will you? How does it feel if that gets interrupted at any time throughout your life? Realistic expectation that I should reach all those cycles. ICU. Oh, hello. Can you hear me? Do I need this? Do I? No? Okay. So we end up in ICU. Okay. Role of social work in ICU. What do we think it is? If I had $1 for every time somebody said to me, I would love to do your job, all you do all day is sit around talking to people. And I think, what a privilege and a pleasure that is. That's what I do. All right? That's my job. Anyway, you can read all that. We problem solve, we enhance well-being, and we interact with people in their environment. So we support people when they're in this type of environment. ICU, death, dying, chronic illness. When our people come into the hospital, you would expect that they have a package of care. In that package, it's from the ward clerk who takes their name and address, right way through to allied health, and sometimes at the end of the day, the cleaners that clean the bed for the next patient or for the one who's died. Social work, in my opinion, is one word. I think we're the voice of the people. When I say that, we're the voice of the patients, the family, the doctors, the nurses, all the significant people involved in the care of that patient. I've put body language in here because to me, when I'm working with families, body language is paramount. A lot of our people cannot actually communicate verbally, as you know. And I've put the micro expressions in there because I see that constantly. Sometimes our patients are conscious, but they can't speak. I only have to look at them, whoever's in the room, and whether they raise their eyelid, or they put a finger up to say hello, or they put a whole hand up. That indicates to me how important that person in the room is to them. So I get told lots of stories with everybody having a vested interest with families and friends. It's my job to try and sift through some of that, and that's not easy sometimes. When anyone goes through to ICU, you'd have to assume there has to be some grief and loss there. Anyone who avoids that is in denial, I believe. I love Elizabeth Kubler-Ross. She came up with the theory of, is it gone? Has it come? Yeah. 5 stages of grief and loss. I've looked at Google since this, and I haven't seen anything that I believe captures exactly what it is so simply. She just talks about all the stages, and you'll all recognize this. So denial and isolation. How many family meetings have I been in and people are just not listening, they're not taking it in. They're in denial of the situation. Angry, constantly see anger and frustration. So it's our job to try and resolve that and recognize it. Often I just have to explain to staff that it's not personal. Bargaining, we all do that throughout life. I see that also an awful lot, especially when it comes to children, and I'm working in neonates, and I might have a young baby where the mum may be a drug addict. I'm going to do a couple of case studies for you in a minute and explain that. Depression. Once you've experienced something like ICU, it does make you question life, and a lot of people do have depression throughout that experience. Acceptance. I love the way she puts this. It's a gift not afforded to everyone. I'm going through my slides quickly because I'm aware we were a bit behind on time, okay? If you want to slow me up, ask me questions, do it. If you're anything like me, I forget what my question is at the end of the session, so do that, please. Anyway, acceptance. It's important for me that people understand about acceptance. It's not that you're okay with the situation, it's just that you've come to terms with it. Acceptance is a gift, and there's not many really that actually come to that stage, not very quickly. I've included here about the implications of unresolved grief because I also work in the emergency department, and I might get people coming in who've got headaches, tummy aches, and often once we get talking to them, a lot of that is unresolved grief. I've had young children come in whose brother or sister have died. They're coming in with all these injuries, simple injuries. And I had a young boy recently who'd been in 3 or 4 times. He'd lost his 12-year-old sister 6 months earlier. Nobody really thought that he was grieving and he was just hurting himself, which we need to identify when people are in ICU, that these things possibly will happen. I'm just going to give you a case study now, just to give you some examples, and you can ask me questions then as well. I had a new mother who was drug addict, and she'd been beaten up by her father of the baby, her boyfriend, and went into early labour. Baby was born, withdrawing from drugs. She was quite distressed herself, the mother, and wanted the father to come and see baby because baby was being transferred to another hospital. There was a lot of chaos in the hospital about this. Nurses become very protective of the babies, and rightly so. They didn't want the father in because he'd beaten up their patient. Security weren't allowing him in because there was a VRO, violent restraining order, against him. The patient was beside herself and they couldn't settle her down. So the police were called, I got involved, and what I actually managed to organise was a quiet area in a room with security and police on the outside, ready to come in if it was needed. These parents had family time to say goodbye to that baby. It did not survive. But my hope there is that they would have learnt a lesson in that next time someone's pregnant, or if he decides to beat up his partner, he might think twice after seeing his baby die. I had another lady, 42 years of age. She was pregnant with her second child, second relationship, and she had an 11-year-old daughter. Husband was a FIFO worker. The daughter went through the whole pregnancy with her mum, very heavily involved. Right near the end of the pregnancy, we were getting concerned about baby, so doctors decided they would bring baby on. Baby was stillborn. Prior to that, we had the opportunity to talk about what would happen if baby was stillborn. So these are some of the grieving stages I'm talking about. The 11-year-old daughter wanted a whole baby, and that was agreed upon in our pre-pregnancy meetings. But what happened when baby came, the dad, the stepdad, and the family, his family, were all in the room, and they wouldn't allow this 11-year-old girl to hold her sister. I was called because the nurses said to me that there was lots of arguing, and their patient was so distressed they couldn't settle her. It's not something a patient needs to go through when she's just lost a baby. I actually went into the room and I couldn't believe what I was seeing and hearing. So I knew the wishes of my patient because I'd worked with her earlier. So I cleared the room. And it was a magical moment, and it's something that stuck with me for a long, long time. We were able to let this 11-year-old sister hold her sister and say her goodbyes. In that, the relationship between the stepfather and the daughter was really strong and bonding. He didn't want to hold baby to start off with, but when he saw her and how precious it all was in that situation, he also had his opportunity to say goodbye. Family, extended family were outside. I had to then go and talk to them. So that outcome in the end was very, very good. So there's a social work role there as well. I brought in this one Aboriginal gentleman because I thought we need to talk about culture a little bit. I don't pretend to understand Aboriginal culture. It's extremely complex, as you probably all know. However, I've had quite a few occasions where I have worked with Aboriginal people in ICU. So I had a gentleman in ICU, and his niece was insisting that we get 2 of his nephews out of high security prison to visit, because it was unsure that he was actually going to pull through. When the niece was claiming it was their culture, and it was very important that the hospital done that, I had to balance the culture, the policy of the hospital, the policy and practices of the prison. So my role was to try and coordinate a reasonable outcome there. Spoke to in my opinion, the most main person was his partner, his wife, and his daughter. And the consensus was that, and this is the words of the wife, she's just trying it on. So I thought, well, that's fair enough. You might as well try it on. Sometimes you get a win. However, the good outcome of that was that I was able to set the prison up to let them know there probably would be a funeral very soon. And it would have been very important for these boys to attend that funeral. And that occurred. So that was a really good outcome as well. How much longer we got? Minutes? 2! Okay. I won't go through those. I just wanted to give you some insight on the role of social work and what we actually can do. And please engage us really, really early in the piece, because we need to get in there early so that we can engage with people, build a rapport, build respect. And if you do that, I've been in many, many meetings where I've been able to turn things around from the family's perspective, only because I've developed a relationship of trust and respect. So please don't just see it that we sit there and chat to people. We do that. But I think we do a lot more. So I'm hoping after today, you might see the role of social work as fairly important in ICU. I think it is, and I think the package of care is important for our people. Anyway, I'm going to finish with this, just so you can all reflect and think, what a wonderful world we actually live in. Thank you. That's it. Do you want me to stop it?
Thanks so much, Deborah. You can leave that in the background while people consider if they'd like to ask a question.
Any questions for Deborah? Yes. No, that's good. A statement, good.
See that we're in the process of selling books at this meeting. Is that I don't know how many people here have read Being Mortal by Atul Gawande, and I recommend that actually every healthcare giver and every human being actually reads that book, because what it directs you is not to do the wrong thing by the patient at the end of life. And to me, the key phrase out of that book was, what sacrifices is the patient prepared to make to stay alive, rather than what I can do for the patient? Because a lot of patients don't want to lose their limbs to stay alive, and don't want to be on chronic dialysis, etc., etc. So I'm just filling out this book list.
We have a question.
Oh, yeah.
Thanks for the talk. In the 11-year-old sister wanting to hold her sister, who are you clearing the room off? The medical and nursing staff? The family, okay.
Yeah, sorry. Thanks for clarifying that. Not the immediate family, no. Are we all good?
Yeah, okay, Deborah, thank you very much.
Thank you.
So our final speaker for this session is Dr. Sam Radford, who's an intensive care specialist at the Austin Hospital and also Deputy State Medical Director for Donate Life. So welcome, Sam.
Thanks very much. I'd very much like to thank the speakers that have come before me, in fact all the people that have come before me. We had a really gracious welcome yesterday, welcome to country, and I really liked the care and thought given to our families, and I was really touched by that, and I would reflect back that thank you and the spirit of welcome that it was put in. I'd also like to thank the people and the families that have come before me in the sphere of donation. That there are families on the donor side, there are families on the recipient side. There's been a lot of ground covered in Australia, and at the heart of all of this, though I'm going to show you lots and lots of numbers, there are individuals and there are all the people that they touch through that. I'd especially like to thank the speakers before me who've done a great job, particularly Tom and Deborah, and I'd ask you both, are you okay, having done the burnout session yesterday? The themes that you've touched on about death and dying and the impact on staff, because I think that was one of the unspoken messages in your presentation, Tom. The themes that you talk about with acceptance and time, these are all themes that run through donation. Donation certainly takes the intensive care experience in the care for families well beyond that and well into the grieving periods afterwards, where we see all of these stages of grieving, particularly acceptance. I share a wall, or my office next door is next door to our grief counsellor at Donate Life. And lastly, I thank Sam Shemmy for doing half the talk for me this morning in the comparison between Canada. thank you, of course, to the convener and the committee for inviting me. All right, so I thought it was important to establish my qualifications as a human being, not so much disclosure of conflict of interest, but instead I want to point out that neither I nor anyone in my family is actually waiting for an organ at this point. I'm a registered organ tissue donor. I've got the card in my wallet. You can all log on and do so quickly while we're giving the talk, or in fact in the satchels there's the paper pamphlets. I've shared my donation decision with my family, and these are the two most powerful things you can do, is to register and to share your wishes. I work as an intensivist in a liver transplant intensive care, and I also work as an administrator, the Deputy State Medical Director in Victoria for Donate Life. And I've got no financial interest in any healthcare related industry, but particularly not in any of the whiz-bang fancy organ support machines. So what about you? How many in the audience have actually had a friend or a family member that has ever needed a transplant? Ever been considered? Wow. How many have a friend or family member that's ever been a donor? Yeah, and that's why it's important to say thank you up front. How many have made a decision, a clear decision, and shared it with their family? Great work, thank you. And how many have registered on the National Registry? A similar number. God, I love working with healthcare professionals. So what are we going to cover? We're going to cover the ongoing need, we're going to cover some international comparisons, we're going to cover off community awareness very quickly, the clinical progress that we're making across Australia as a program. I'm going to talk a little bit about the way forward, and I'm going to give you an insight or a vision as to what I think a great process looks like from end to end. So here's the need. This is the waiting list taken as of 1st of September. It doesn't go away. We chip away at it. I'm really delighted to see that, you know, for the first time in my memory, we have less than 1,000 people waiting for kidneys. So the overall waiting list is 1,361 as of 1st of September. Now, waiting list is just a snapshot in time. It doesn't reflect people going on and off through mortality. It doesn't reflect people going on and off through improvement in their conditions or deterioration in their conditions to the point where they can't be transplanted. But it's a great, simple measure of the ongoing need. When I started in this sector in donation back in 2009, the mantra there was more like there's 15, 16, 1,700 people needing transplant. And it's a delight to be chipping away at. I don't think these are numbers we can scream from the mountaintops yet, but it is a delight to thank ICU teams and everyone involved for chipping away at these numbers and getting them down. It's also important to remember that some of these are relatively small cohorts. If we break down what's the current waiting list for hearts in Western Australia, you may well be able to count it on one hand. Yes, or even on two fingers. Sam referenced this slide this morning, and I thought I'd just drill down into it a little bit further on. This is the inverted pyramid picture that talks about the limited opportunities. So 24 million people, limited number of deaths in hospital, potential donors. Yes, you're very right, Sam. These, in fact, are the DBD or brain dead potential donors. They're easy to describe and therefore easy to audit. And if we look at the recognition rate and approach rate, that's a 97%. So you can imagine that with DCD, which is a lot more nebulous and a bit harder to define, the criteria of who might be a circulatory death donor, that number will come down, and that's okay. And then out of that brain dead pool, we have a consent rate of 62%. I reckon that's an obvious place for more work. 435 actual donors. As of this morning, for this year, we had 400 donors nationally. So, 435 donors translates into 1,239 transplant recipients. So, in Australia, a utilisation rate of 3.4 organs per donor. We hear a lot about the World League table leader in Spain. Their utilisation is substantially less, at 2.32 organs per donor. So there's some differences there. We'll try and explore that a little bit later on. So, things that are important to Australia. Beating the Americans. This is Perth, 1983. the first time the America's Cup had left the US. Subsequently, we had to give it back and to the New Zealanders, but it was a pretty important time. This is what Australia likes doing. We like winning stuff. This is the Ashes coming back, also in Perth at the Wacker. Very important moment. I recognise this as a binational conference, so well done, New Zealand. This time last year at ANZICS, this was going on. So that's what we like as countries. So we weren't too chuffed when this was the sort of leaderboard, pre-Kevin 07, that we saw. We're not winning. Why is it so, and when do we fix it? And how come these guys are better than us? And there's an inherent, not nastiness, but there's a jingoistic nature of, we need to be better. We need to be better than these people. And so this is another part of the ongoing need, that Australia demands and needs transplantation to happen, and it demands and needs us to be as good as what our transplantation outcomes are, which are world leading. So this was the scene before the reform. From the same source, from the International Registry on Organ Donation, here we have a league table back in 2015. I'll give it to you in a more digestible format in a minute. But we can see that New Zealand have done some proud work in increasing their numbers up to 128% of their 2007 numbers. So that's a donor per million population number of 11.5, up from 9. And Australia has more than doubled what we were like in 2007, up to 18.3 donors per million. This is as per the end of calendar year last year. Here we are, just zoomed in a little bit more. So this is where Australia was at the end of last year. Here's where we want to be. So targets, numbers, they're not dirty words. These are the conglomeration of a number of family stories, but this is where we want to be. 25 donors per million by 2018. And it's a significant target, but we hope that it's an achievable one. For the record, this is where Victoria was at the beginning of this week. This is where we were, at last year. Victoria had done 21.2 donors per million population. There's a spirit of healthy competition that has been told by the Ernst & Young Review that we're meant to be fostering between the jurisdictions. So I'd like to point out that by the end of this year, we hope to be beating Austria in Victoria, that is, if Victoria was a country in and of itself. So community awareness is a key part. This is not just a clinical journey, it's a journey through the community, and having families that are aware and bringing this up makes the job substantially simpler. There's web-based campaigns. Here we have some of our Western Australian staff promoting stuff. There's a tram, bright pink, and we have a palpable sense of families knowing, understanding and raising donation. But we need to rely on more than that. So there's been a widespread, there's been a big growth in numbers. And if we're going to grow numbers even further, how are we going to achieve it? It's going to be through further implementation and normalisation of donation after circulatory death. It's going to be looking at an expanded pool of donors, and it's going to be looking at increased consent rates. So how do we do that? So DCD, donation after circulatory death. It's fair to say that families really understand circulatory death very well, and that intensive care teams inherently feel a bit icky about it. And that's okay, and that's normal. But for families, donation is donation. We tie ourselves in knots thinking about it, but I put to you that the vast majority of the problem is sort of between here and here. We've got to make sure that our end-of-life care processes are right. We've got to make sure that they're solid. We've got to make sure that donation is seen as a normal part of end-of-life care, and that our end-of-life care doesn't change in terms of family communication, in terms of patient support, in terms of terminal sedation, regardless of where the donation is proceeding. So DCD has grown in numbers over the last few years, and we can see that now we have a 28% of donations in Australia are via the DCD pathway. So we're doing better on this international league table in terms of DCD. So overall that translates to 5 donors per million DCD, and really we're close to the Spanish and even the peaks of what the UK and the Belgians are doing, and we're certainly ahead of many other countries. But it's not uniform. There's variability across the states, and we can see that DCD hasn't necessarily produced the same results everywhere. As my mother said, it's not good, it's not bad, it's just different. And exploring those differences has been a substantial body of work with the Donate Life Collaborative. That's been a meeting of teams from across all the different jurisdictions to share the ideas and to drill down into what those differences might be. Could it be that there is vast distances impacting on DCD, that actually families just, not only do they want to go home, they've booked the plane and they're going home, and that extended time frame cannot be for them? Could it be that really with very low intended rates, so that's a DCD where it was planned and set up but didn't occur, could it be that if there are low intended rates, well, we're not venturing, we're not going, and that there is opportunity to push there? Just like in intensive care practice, we think about sometimes you've got to have a negative laparotomy. You've got to take someone back to theatre and find a virgin appendix. Venturing is where we will find the answers. But certainly, as I've already said, DCD donors can be harder to describe and can be harder to identify, certainly from an audit point of view. When we look at DCDs and that variable pathologies that lead up to it, we can see here that not only is it head injury, stroke, trauma, hypoxia, but we've got non-neurological cases are starting to creep in and be represented. So that could be patients in my unit dying of liver disease. That could be patients dying of spinal cord injury. We could have patients that are just outside the box of what we used to think of as the typical donor, not just anoxic brain injury after cardiac arrest. I mentioned intended donations, where donation doesn't proceed. And the big blue chunk is, of course, where they have had a planned DCD and the death has occurred outside of time limits. There are tight, rigid time limits to preserve acceptable durations of warm ischemic time so that there isn't additional injury to that organ, making it non-functioning and therefore not able to be transplanted. But that's not the only reason. There's a whole host of other reasons, including where we've drilled down and found that medical suitability actually just wasn't there. Case last week, that exhaustive searching and, oh, actually that might be a melanoma on their back. And that changes everything. So there are declines from family after initial consent, and we can get situations, as you can imagine, with a waiting list of 2 cardiac patients in Western Australia, it might be that there are no suitable recipients. So intended DCDs happen for a variety of reasons, but by far and away the biggest is not dying within timeframes. If we're going to expand the donor pool, I can tell you now that our donors are getting older and sicker, and they will continue to do so. So are our recipients. They're getting older and sicker too. And we've got risks of chronic disease, diabetes, obesity, vascular disease, and guess what? So have the recipients as well. And so these all have potential impact on organ function, particularly kidneys. Infective disease transmission. We used to worry about hepatitis. We're being told now by the hepatologist, no, curative disease, not just for the donor or potential donors. They can be treated for their hepatitis C long-term in the lead-up, but also for recipients. So there are plenty of recipients out there on hepatitis C waiting lists. And that even if you do put a hepatitis C infected organ into recipients, the treatment now for direct-acting antiviral agents is so helpful that there's even debate as to whether this just be moved into a normal sphere of donation as opposed to extended criteria. So that landscape is changing very rapidly. HIV made the headlines a few months ago when in the US HIV donation has occurred and in fact become legalised in certain jurisdictions there where it previously had been illegal. Because HIV is a chronic disease, hepatitis C is a chronic disease. Being a Cat1 liver recipient waiting with imminent death in the next 24 hours, that's not a chronic disease. Waiting on ECMO for lungs, that's not a chronic disease. They'll take just about anything. And it's all made, these decisions are all made with reference to the transplanters and to the recipients. And even some brain malignancies can make for successful donation outcomes. So this is American figures showing the utilisation of drug-affected donors, now at sort of 11.6%, so certainly the tide is changing. So, as I've already said, the immediate risk is what really makes the decisions. And the best suitability decisions aren't made based on arbitrary criteria. Okay, they're below this age, they're above that age, it's this time frame, it's that time frame. the best decisions are made in consultation with the transplanters. And that's where Donate Life operates, in the middle, so that the transplanters are at arm's length and not sort of peering behind the curtains, but you go through us and we confer with them to help make great matched decisions. So if we want to increase consent rates, and we survey Australians, traditionally about 80% of them say they support donation, but really only 62% say yes when they're asked. Maybe that's something to do with the decor in our waiting rooms. Maybe it's a great big lesion of what has happened to them through this journey, and maybe it's how they're asked. So I would put to you that a number of 80% is about ideal. More than that, you've got a really special population, i.e. just the ones who volunteered it. Less than that, maybe you're not asking in just the right way. So we need well-trained staff. This is where I used to be 10 years ago, 45% sort of type consent rate. I was an intensivist who thought I knew best. I know the family. Of course, I can ask them. I don't need special training. And had I been like that, I'd have got about a 45% consent rate. So these are studies from Virginia Lewis and a 14-centre observational study done over the last 2 years. If I'd gone and had FDC training, I'd have got to 55% consent rate, and this is a great improvement. But when you've got an FDC trained or family donation conversation trained requester who's not part of the clinical team, working alongside a clinician who is leading it, then you've got a 75% consent rate. So getting pretty darn close to a gold standard. All right, so we need the right people at the right time, and they need to be talking to the family as well. I'm going to take liberties, if I may, and just say these are the principles I work by. I've deliberately changed the slides to the colour of my hospital because this is what we do. So we identify everyone early in terms of mortality. We have an easy, we approach families early to warn them about bad outcomes. We support the families until there's a consensus of futility, that acceptance. We make sure that there's timely referral to available donation staff. We do a daily huddle at a whiteboard and we talk about who might be needing end-of-life care. And we often do that well before there's a universal acceptance of futility. We make sure that the AODR is checked every time, and this has saved people from idiots like me who thought, oh, no, they won't say yes or that won't happen. Having a system has saved donation opportunities. We make sure that 100% of dying patients have got the best possible donation discussion, timing, place, people, pace, content, and we make sure that all the suitability things are assessed. So I'll just skip through to the end. Really, the long-term emotional care of the donor family begins at admission. It continues through the treatment of the dying process with or without a donation outcome, and it's ongoing for years after death. Thank you very much indeed.
Thank you, Sam. We've run out of time for this afternoon. Before we finish, I've got some important announcements for you. If you're going to the Cottesloe Beach Hotel this evening, the buses will be leaving from in front of the conference centre, the level 1 plaza entrance near the Adina Apartments. You need to be there. They'll be leaving from 6:45 p.m. Please be ready and waiting 10 minutes beforehand. And if you're planning to go to the dinner tomorrow evening, you need to put your, if you want to sit on a particular table or with a particular group of people, you need to put, there's a sticker with your name on it, you need to put it on that table. They'll be closing down that list early tomorrow. So this afternoon's your last opportunity really to sort that out. So I'd like you to join us in thanking the panel for this afternoon's presentation.